All right, welcome to Learning from Caregivers, an interview series where we'll be digging into the latest information from both on-the-ground caregivers as well as caregiving scientists to help people support the needs of older adults, their families, and communities. This is a podcast for health professionals and for all of us who care for older adults. My name is Joan Monin, and I'm a professor at Yale School of Public Health. Today, we're going to be talking about why women have Alzheimer's disease and other dementias more than men, and whether hormones have something to do with it. I'm so happy to have with me today Dr. Carolyn Fredericks and Jordan Galbraith. Dr. Fredericks' research focuses on preclinical Alzheimer's disease and on less common Alzheimer's variants, using advanced imaging tools to better understand how Alzheimer's disease progresses through functional networks in the brain. Dr. Fredericks also sees patients with a variety of cognitive and behavioral concerns. She specializes in the diagnosis and treatment of neurodegenerative disorders. Jordan is a third-year MD-PhD student who is completing her thesis work in Dr. Fredericks' lab, and she's interested in studying women's increased risk of developing Alzheimer's disease, and specifically how hormonal shifts relate to changes in functional networks and cognition in the years surrounding menopause. Welcome, Carolyn and Jordan. Thanks so much for sharing your knowledge about this science with us today, and just really highlighting this question that I feel like so many people ask me as someone who helps people living with dementia and their caregivers. So first, Carolyn, maybe you can start with, some of the facts and figures of the public health issue of Alzheimer's disease and related dementias, and this gender disparity that we see with ADRD.
Absolutely. And thank you so much for having us both. I think in terms of just the overall statistics about sex and gender and Alzheimer's disease, we know that something like 2/3 of Alzheimer's patients in the U.S. are women. And as our population ages, of course, that number will grow. I think one common assumption is that this has to do with women's increased longevity. Many more women make it to their 90s than men. And so, of course, there would be more women. But it's definitely a lot more interesting than that. For example, we know that even in early onset Alzheimer's disease, where people have symptoms that begin before the age of 65, women still outnumber men in similar ratios. We also know that genes that are really important for Alzheimer's risk, such as the ApoE gene, seem to affect women much more so than men, especially when someone has just one copy of the risky gene. And so there are a lot of clues that tell us that this is not a simple question of longevity.
Yeah, that's so interesting because usually the thing that everybody says is that older women are making up, this difference in who gets dementia because they're just more people that survive that are women.
Right.
But that's not really actually what's happening.
And to some extent it's true. More men, for example, have vascular dementia, which is related to very common vascular risk factors like high blood pressure, high cholesterol, sleep apnea, smoking, diabetes. Many conditions that tend to affect men more so than women that can create kind of a different kind of cognitive impairment. There's a gender component to it too, though, which is really interesting. If you look at cultures where women had earlier exposure to higher education, to intellectually challenging occupations, to opportunities for cardiovascular exercise in early and midlife, in those cultures, the ratio of Alzheimer's incidence by sex is more equal than in cultures that were later to adopt those sort of social advancements. So there's a gender piece too.
Mm-hmm. Yeah, so interesting to think about the gender role and cultural influences too, in how often this happens. So Jordan, I'm going to ask you about some more specific things. I have a question about women's elevated Alzheimer's disease risk. What are some of the sex and gender-based contributors, and to what extent might some of those elevated risks be a simple result of women's greater longevity?
Sure. Yeah. So this is something that we've touched on, but I can add some details to our previous answer. And so I'll start by just echoing that we know that age is the biggest risk factor for Alzheimer's disease. And so when we talk about sex differences, it is important to acknowledge that that is probably part of the piece for why women are at higher risk. However, we know from studies that are age matched or studies where we have, for example, cohorts of people where women and men live around the same age, we do think that there is still other pieces to the puzzle as well. And so for some specific examples, we know that when it comes to sex differences, the greatest genetic risk factor for Alzheimer's disease is the ApoE4 allele. So ApoE is a gene that everyone has, and you can have different variants or alleles of the gene that you inherit from your mom and dad. And there's one allele that is particularly increasing your risk for Alzheimer's disease, ApoE4. And so while both women and men can carry this allele, when women are carriers of it, they're much more likely to develop Alzheimer's disease compared to men that are carrying it. We also know that women that carry the ApoE4 allele have faster cognitive decline compared to men that carry it. Another thing that we talk about when we say sex differences, a big topic is hormones, and especially there's been a lot of work in estrogen. And so we know that as estrogen declines, you get more neuroinflammation, you get oxidative stress, you get more cellular dysfunction and brain atrophy. So we do think that certainly the shift in hormones over a woman's life, but also including the menopause transition, may also be creating vulnerability to Alzheimer's. And then further, you also ask about gender, which is really important. So Carolyn already mentioned the lower opportunities to education, higher education, and professional opportunities for women. In addition, there's maybe perhaps historically limited physical activity for women, which could also put your brain at risk for Alzheimer's. And the last piece that I think that we don't talk about enough is that women are more likely to be caregivers in society compared to men. And in fact, we know that there's around 12 million caregivers that provide 16 billion hours of care to people with Alzheimer's in the United States. We also know that more than 60% of those caregivers are women. And when we include caregivers of all people with Alzheimer's disease, about 1/3 of those caregivers are daughters. And so we think that this is also something else that we should be talking about and paying attention to, because that chronic stress in being a caregiver for your kids, for your parents, and also for a spouse may also be putting you at greater risk for developing dementia.
Yeah, definitely, because there's all these different things happening for women. I feel like at the same time, there's, menopause, there's caregiving for your parents or potentially your spouse. There's, taking care of children. There's a lot of stressors going on for women, and, along with the biological and kind of the environmental roles that people play, it may be hard to kind of distinguish what are the things that we can do to help women lower their risk, right? It might come down to just behavioral, healthy lifestyle things, and I think that's what we have so far. But I wanted to really dig into more of this menopause piece, because I think especially right now, there's so many books out on the market, like popular books and even fiction books, that are talking about menopause a lot more than they used to. And even, some of these like fiction books are putting in like statistics about your risk for Alzheimer's disease with menopause, which I think is just wild to be having that be part of the conversation that a lot of middle-aged women are getting together, talking with their friends about these days. But in terms of cognitive symptoms surrounding menopause transition, can you tell me a little bit more about that? Like maybe what's normal, like what is a sign that there might be some kind of risk for dementia, and maybe why, this is happening to some women?
Yeah, absolutely. And I will say that I'm really happy to hear that the conversation is happening. I think for a really long time, people just weren't willing to talk about it or didn't feel like they could share that information with their friends and family. So it's really cool that this conversation is going, and I think it'll be helpful for things like this to talk about the real risk. And so I will say, when it comes to just general cognition in menopause, I do want to note that menopause is just as like diverse as the women that go through it. So it's very heterogeneous. Some people don't have any cognitive complaints. And those that do, there's a really wide range between just subjective feelings of like brain fog. That's a really common complaint. Some memory lapses. So that's one end of the spectrum. But it can also be that women are experiencing really like dramatic shifts in cognition, where when we actually test their cognition, they'll have deficits in certain areas, one of which being verbal memory. So that's something we talk a lot about, both on the menopause side, but also on the Alzheimer's side. So for example, being able to like remember and repeat back something that you heard earlier. So that's a common test. And so as far as what's normal and not normal, I think I'm going to have to shift that to Carolyn, since she's caring for these people. But just to say that it's a whole spectrum, and we think that it might have to do with some of these things that we mentioned earlier, such as changing hormones and changing expectations in your roles in society.
Yeah, I think that's absolutely right, that there's such a wide variety of experiences. And to your point, Joan, about how complex this gets when we take into account all of the added responsibilities and stressors that women are often going through at this time in their lives, I think it becomes even more complex. So just as, for example, we know that Alzheimer's risk has something to do with gender-based factors like access to education and cardiovascular exercise, which previous generations may not have had as women, to some extent, I think there are physiologic parts of menopause that have been blamed for brain fog and for other cognitive symptoms, things like hot flashes resulting in poor sleep, things like mood symptoms related to menopause. And while these may well be an important part of what women are experiencing, there's also a risk of dismissing real cognitive symptoms as simply the result of her hot flashes or her mood shifts. And so I think we have to be mindful that there's probably a whole spectrum of things going on. Something I also want to highlight is that women, over the trajectory of their lifetime, verbal memory is actually typically a strength at a population level when you look at women versus men. So across the population, women typically outperform men on these kinds of tests. And one of the early findings that our lab had that got me really intrigued in all this was the finding that, especially if you look at women who are aging, in their 30s all the way up to age 100, women, compared with men, have higher connectivity in a network that's really important for subserving that verbal memory performance, called the default mode network. It's also a network that's highly implicated in Alzheimer's disease. And women have a higher amount of connectivity essentially in the back of that network across the lifespan, but especially in their 40s and 50s, which of course are the decades that surround menopause. And furthermore, that higher connectivity, especially with that network connected to the mesial temporal lobe, which contains some other structures that are very important for memory, seems to correlate with their memory performance, i.e. that signature of higher connectivity seems to support this improved verbal memory at a population level, again, compared with men. And so I wonder if you could use the analogy of a highway that's getting a ton of use and that becomes worn down over time, that this higher connectivity, which is working out well in terms of women's verbal memory performance, actually paves the way for increased risk of neurodegeneration later. Maybe it becomes the superhighway along which tau, the Alzheimer's protein, can travel more efficiently. And so it ultimately becomes a vulnerability. So again, just trying to shed some light on the complexity around these cognitive changes. I think a lot of the women who come to see me in clinic around the menopausal transition with cognitive symptoms, their complaints are typically more what we would call related to complex attention or executive function. So their ability to organize, to multitask, to get distracted by the phone and then be able to come back to what they were doing and efficiently go back into that first task. And those are some of the same symptoms that we'll see in people with sleep deprivation related to sleep apnea or new parenting, and a number of other kind of clinical conditions, including thyroid disorders, which are all things we ought to check for. I do think, though, that in another way, menopause seems to set the stage for later vulnerability to Alzheimer's disease in ways that we're just beginning to get our heads around.
Yeah, that was going to be my next question but super fascinating about kind of the different cognitive skills that women may be using more in their roles in society than men, and how that could lead to vulnerability rather than kind of protection. Like, you would think maybe it could go either way, like if you're using those skills so much that you have like extra leeway, but then also hearing from you who's really focusing on like the neuroscience of how tau is involved in these processes. But it just really makes you think about like, what are the ways that men and women are differentiated in cognitive tasks throughout our life, and how this, might relate to some of these changes. I think about like the emotional burden aspect and the kind of the care work that women are doing all the time, is just thinking about like, oh, what summer camp am I going to have to sign up my kid for when it's like February? And that's maybe not something that you're thinking about yet. But, women are more likely to be thinking about those things along with things that they're doing in their job. And then also, making sure that they're doing something for their neighbor. And then, so they're thinking about a lot of different things, which speaks to the multitasking aspect, not across the board, but it tends to be like the role in our society, at least in the US, that women are doing more of that kind of considering lots of people's different needs and thinking about preparation for meeting those needs. That it takes a lot of cognitive and emotional work, which, thinking about the emotion and cognition interaction too, maybe kind of an interesting thing to think about as well. And I'm sure you have in your lab. But yeah, the menopausal transition and how that might impact the later cognitive decline for women, I think is like something that's on a lot of people's minds as they're starting through menopause and thinking about, well, how do I talk to my doctor about this? What kind of therapies should I be doing or not be doing? What's the latest science on menopause so that I can decrease, that risk factor later in life? But maybe you could just tell me a little bit about how menopause might increase a risk later on for women.
Yeah, I think that there's a couple of ways in which we feel that menopause does set someone up potentially for dementia. One is that there are studies, they're very sparse, but there are studies about the age at which someone stops having periods, and how if you stop having periods earlier in life, and it's thought to maybe relate to your estrogen exposure over the lifetime, you might have a greater risk for developing Alzheimer's. We also know, and I know we're going to get into this, that there have been many conflicting studies on the starting of hormone replacement therapy around the menopause transition, and how that might increase or decrease your risk depending on a number of factors. And so while we know that these things seem to be related, we really don't have a ton of information. Like, this is something that's being very actively studied. Like, what is the role of menopause and Alzheimer's risk? And like, which piece of it do we want to target in order to lower someone's risk? I also think, though, I will mention that this is really exciting that we are seeing these cognitive changes, these brain changes really early on in menopause. And in fact, before someone actually officially is in menopause, while they're going through the transition, what we call perimenopause, because this suggests that there is a time period where we could intervene. Perhaps there's a therapeutic, perhaps there's a behavioral modification. And so this is something that's really exciting for us as researchers and clinicians, because we think that there's actually maybe something we can do about it. We just have to figure out which piece of the puzzle to target.
Yeah, so another question I have is whether there's a critical window for effective hormone supplementation, and how has the hormone replacement therapy landscape changed in recent decades, and how might that impact its risks and benefits?
This is such an important and evolving question. I think During the time I was in medical school, the WHI study results that implied that hormone replacement therapy was actually a risk factor for dementia and a number of other adverse health outcomes really kind of swung the pendulum towards millions of women stopping HRT or electing not to start it, and towards us generally understanding this as potentially a risky therapy that before had been administered to many women with the thought that it was of great overall health benefit. And I think the pendulum is coming back towards the middle at this point. It's a complex landscape because I think even the specific hormone treatments that we offer have evolved quite a bit since the time of that study. And so the HRT that a woman receives now is quite different and potentially significantly safer in some ways. And I can't get into the kind of molecular details of why. It's outside of my expertise, but it's a quite different therapy than what the WHI data were based on. And I think further, there's this idea of a critical window. So the idea is that if you start estrogen supplementation early enough, say at the time of menopause or even before it, that may be more likely to give you the benefits of ongoing estrogen, which has clear neuroprotective effects across the board, compared to someone who has been essentially in an estrogen withdrawn state for years after formal menopause and then begins to receive supplementation. The thought is that perhaps the estrogen receptor systems that are so prominent in the hippocampus and other areas that are important for memory, after a few years without estrogen, have regressed because they're not getting exposed to the hormone, and so those networks just aren't sustained. Whereas if you start therapy earlier, you're able to take advantage of those neuroprotective circuits and systems that are still in place from prior to menopause. So in broad strokes, that's sort of where the field is at. But there have been very mixed studies in recent years. You'd think, okay, we'll just start it early and there'll be a benefit. It's certainly not that clear. And even recently, at least one large study showed an adverse effect of even earlier hormone supplementation on women's risk of dementia later. And that's sort of with more modern HRT. Other studies, though, have shown the reverse, that there is kind of a critical window where if we intervene early, there could be a cognitive benefit. And so as a clinician, I'm still left at this point saying, well, if your OBGYN feels like you'd benefit from HRT for other reasons, great, but I can't recommend it to you on the basis of its cognitive effects alone. And I hope that we won't still be in that sort of agnostic position a few years from now. I think this is a really actively evolving area of inquiry.
Yeah. So that suggests that we do need quite a bit more research to really understand how to help protect women from having this higher risk of dementia through care at this menopause stage. Would you say that's true?
We do, absolutely. And to Jordan's point, I think it's a really exciting time because we have all these puzzle pieces, like the one I gave you before about the network shifts that our lab observed, but we also have data from women who've had very early menopause surgically as the result of needing to have an oophorectomy for a medical reason. We know those women are at higher risk. What can we do to protect them? There are a lot of data points that need connections. Mm-hmm. And so I think it's a really exciting time to be in the science.
Yeah. It'd be super interesting to understand more about, those earlier years too, for different types of hormones that are given throughout a woman's life, right? Even in the teen years and during pregnancy and right after you had a baby and all these things to really look at someone over time to see what their risk is.
It's so important, and there's just so much heterogeneity. Like you can imagine, one woman who essentially has pregnancies from menarche to menopause and nurses her children after each birth versus another woman who may choose not to have children and may be on hormonal contraception and may have a surgical procedure after which she receives estrogen supplementation for her uterine lining. There are just so many potential combinations. And I think exploring the entire range of women's experience is really important, but relies upon almost exhaustive data to capture adequately what any individual woman or any person who receives these hormones. And of course, even your typical man has some estrogen as part of his endocrine system as well. Testosterone is aromatized to estrogen, and that may have impacts on his lifelong cognitive outcomes. So I think we need to really be thinking much more broadly about hormone exposure across the lifetime and what it means for brain health.
Yeah, really important to talk about those widespread implications and the diversities of people's experiences. Because you often think about, like in general, you have kids in your 20s and 30s, but now women are having kids, like in their 40s and 50s sometimes. So they're in perimenopause, or they're having to get, breast exams, for the risk of breast cancer while you still might be nursing, right? Which you're not allowed to do. So there's all these different things happening for women at different times, and shifts in how our culture is changing in when people are choosing to have kids, if they do have kids, So a lot of people are not having kids. What does that mean for women? So it's fascinating to think about the diversity and also the impacts on men, or, people of all different genders and sexual identities, and things like that too, because that's also a way that we can find out about hormones too, right? Is with trans people and things like that, because they're getting hormones in a different way than maybe someone who is menopausal is getting hormones. And so then how does that relate to cognitive functioning as well?
I'm so glad you brought that up, because in the case of individuals who identify as gender minorities who may be receiving hormones as part of their gender-affirming care, what an important way to examine how brain networks that have sort of been brought up in a very different hormonal milieu respond to supplementation of estrogen or testosterone or other sex hormones. It's just such an important case for us to understand in terms of the impact on brain aging.
Yeah, absolutely. And then also, animal models that are so sexually diverse, and also, impact with their community and how they also change, their hormones and sex in different ways, and how that can relate to some of this research as well.
Absolutely.
Yeah. So just finally, to go a little deeper into the amyloid and tau aspects of the brain, and kind of the differential ways that those kind of impact men and women. Maybe you can say a little bit more about that. I know you said that some of that in the beginning,
sure,
but maybe a little bit more detail for us.
Yeah, there's so much more to say.
Yeah.
And I think the whole amyloid and tau thing, there's been so much actually even in fairly mainstream media about the amyloid hypothesis and have we been too attached to the So I think there's a lot of public attention on what's actually a very complex physiology. The brief version in terms of my understanding of kind of where the latest literature has landed us is that the two pathologically defining proteins in Alzheimer's disease, so amyloid and tau, we used to think that essentially, once the brain is saturated with enough amyloid, which quite early in the process of neurodegeneration kind of becomes diffusely spread across the brain, doesn't have a specific anatomy that it goes to. Like once it starts, it's essentially all over. That once there's a certain amount of amyloid, tau starts to spread. And so tau comes later. Tau is the one where it is in the brain is where your symptoms are. So if it's in the memory structures, you have memory symptoms. And so a lot of our early treatment targets were these amyloid antibodies. Can we remove the amyloid early and thus kind of stop the process in its tracks? I think what's become more apparent recently is that so many of us by midlife have a significant amount of tau, perhaps just in the brainstem or just in the entorhinal cortex, or these very kind of small core mesial temporal structures. And so what amyloid seems to be doing is allowing tau to move out of those structures. And I say all this by way of preface because as far as we can tell, women and men aren't so different in terms of how amyloid builds up in the brain. It's about how tau spreads once amyloid is high. That's where I think we seem to see the most important sex differences. So it's almost like tau spread is more aggressive in the setting of the same level of amyloid. You can flip this around in an interesting way, too, because another way to look at it is that for a woman with a given stage of Alzheimer's disease, say a woman who's in the mild cognitive impairment stage, she will often have more tau than a man with similar clinical symptoms. So in a way, you could think of this as a marker of resilience. But also, if you actually just look at the tau in the brain, it is spreading faster and more aggressively over the course of her illness.
Wow, that's something new that I've learned today. You can even be focused on dementia caregiving research all the time, but it's so nice to be able to talk with you and hear about what the latest findings are from your lab. And I think that's a really important one to hear, especially given all of the talk about, the amyloid hypothesis and things like that, to really get more details about these things. So thank you so much for, sharing with all of us some of this information. And I hope that we can, hear more on the latest findings. And Jordan, I just wanted to thank you so much for, going into this field and focusing on this topic. It's so important to have junior scholars be interested in paving the way for new information. I thought, not to put you on the spot, but I'm just wondering how you got interested in this topic and why you decided to work in Dr. Fredericks' lab.
Yeah, sure. So I think a lot of us that come into the Alzheimer's world have a really personal connection to it. So one of my grandfathers, unfortunately, developed Alzheimer's later in life and died with Alzheimer's. And I think that seeing, his development of his illness as well as just how all of the family had to come around it. It was just such a heartbreaking experience. That's one of the toughest things I feel like I've been through. And so I think it really inspires me and grounds me. And when, even when I'm talking about, women's experience with Alzheimer's, everything that we do, including studying women specifically, is going to help us to understand the mechanisms of Alzheimer's in general and really help anyone with Alzheimer's. And so as I'm making discoveries, making little PowerPoints, being invited to talk to people about it, I'm really thinking about him. And it's something that also I think is inspiring me to go into the field of neurology. So I hope to be a neurologist following my training. And so thank you for this opportunity to talk to people and to, let people into this world, because I think it's super important. And the more we talk about these issues, the closer we get to finding a cure.
Yeah. Thank you for naming that. When we talk about estrogen and things like that, everyone has estrogen.
Right.
And it's important to know about it so that we can help, men and women. And thank you for also, sharing about your grandfather, because I think a lot of us who are in this field, even if we didn't go into it with people that we knew in our family, it's likely that we will all face it.
Right.
And I think it's really important for us to just be prepared, not be dwelling on that, there's going to be suffering or hard feelings, but also just to be prepared, to understand how to support people, how to help yourself have good brain health, for you and all of your family members. And so I think sharing this information today is one of those steps to really raise awareness that we need this research, that we need to tell people about it, and that we need to be kind and support people in our communities with whatever they're going through in life. So thank you so much for being here today, and I look forward to further conversations with you.
Thank you.
Thank you.
Thank you.